This first segment, actually the first couple of segments, a number of people here probably know, as much or more than me about the policy related aspects of the Medicaid program itself, as well as some things about its enrollees. But, at the same time, we want to make sure everybody's kind of got a base understanding of the program, because that has real implications for the shape of the data, for what you can find and what you can't find in the data, for the variations that you see. In a way similar to, if anybody's seen our Medicare 101 workshop, we kind of talk about how the data are processed and the forms that are used and how that ends up translating into the shape of those data files. Similarly, knowing some things about the program are going to help you to understand some potential issues that you could run into and why those might be there, so that you can kind of plan as you're making a data request or as you're using the data and so on. So we're going to cover history and basic structure, services covered, some notable features. I do want to make a special point about managed care. And lastly, of course, Medicaid expansion eligibility under the ACA. So we have the inception of the program in 1965 for the Social Security Act, Title 19, we had Medicare and Medicaid. Now, of course, the important thing to keep in mind is that Medicare is a federally funded entitlement program. Medicaid, on the other hand, is a joint state and federal social welfare program. And so you have federal and state dollars, you have federal and state policy, as well as how states choose to implement federal policy. And of course, you have federally granted flexibility that allows states to kind of administer parts of the program that are optional, that allows states to kind of make some of their own decisions because they do have some of their own money in the program. For the full act, you can actually go to that link. So this is the FMAP, or the Federal Medical Assistance Percentage for Medicaid, and the multiplier is the FMAP percentage. So FMAP is the FMAP and the multiplier are a system that kind of allow the federal government to calculate how much state dollar matching is going to happen. So FMAP uses a formula that importantly takes into account per capita annual income for a state compared to the national average. And then the multiplier uses that percentage essentially to say basically how much dollar for dollar is going to be federal assistance to the states. So by federal law, that can't be below 50%. So you'll note that this ranges from 50% upward all the way up to just over 75%. So there is variation in the federal dollars that are used to support state administration of the Medicaid program. One of many sets of variation across states. You can also see that there are a number of different policy changes, sometimes in programs that are not specifically Medicaid, but they have implications for Medicaid. So we have the Children's Health Insurance Program in 1997, the Medicare Modernization Act in 2003, which created Part D benefit. So that shifted coverage of prescription drugs for elderly Medicaid dual enrollees. So people who are on both Medicare and Medicaid. This shifted pharmaceutical drug coverage away from what in the past where Medicare had not had pharmaceutical outpatient coverage. All of a sudden it did. And since Medicare is a primary payer for duals, that can shift how which program is paying for what. And then finally, of course, in 2012, we had the Affordable Care Act, and that, of course, provided states the option to expand Medicaid eligibility to new eligibility groups. Of course, we're going to say this over and over again, but it really matters when you're trying to create a useful analytic file, when you're trying to answer questions about the program and how it's administered. There is just so much state variation in federal spending, as we saw with the FMAP and modifier percentage, with eligibility and eligibility groups that are covered, and with the benefits that are provided. So the federal government sets basic rules on eligibility and benefits. Some are mandatory requirements. States administer the program and they make many choices on eligibility, on optional covered services, and on payment levels. And so again, you've got this kind of state federal amalgam that results in, on the one hand, we look at this as a federal program. On the other hand, it's actually a federal and state program. And that results in just a lot of potential variation in all of these different categories. There, of course, are people who are in both programs of Medicare and Medicaid, people who are disabled or aged eligible, who qualify for Social Security disability insurance. You have aged low income. So if to that point, if somebody is low income, so you could think about this as Medicaid first or Medicare first. In other words, does this person spend down over time, for instance, and become eligible for Medicaid? Or were they already low income covered under a Medicaid program and they, for instance, aged into a Medicare program or were determined to be disabled newly? So those are kind of two different populations. And so dual eligibles is itself kind of a mixed set of eligible individuals in the same way that Medicaid is, in the same way that Medicare is. They represent different eligibility groups. So dual coverage, Medicare is the primary payer for most inpatient and outpatient services. And again, if we're talking about the Part D prescription coverage, Medicaid covers co-payments and deductibles, pharmaceutical coverage prior to 2006, and nursing home services, importantly. One thing to note, I think we actually talked about this on the next slide. Yeah, so covered services, we have in Medicare, if you want to think about it, Medicare basically covers healthcare. Generally, it's consistent nationally. There are some regional coverage determinations that might add in some variation, but generally speaking, Medicare is a pretty standard program nationally. Part C, it adds in possibilities under managed care, a different way for paying for services and for enrollees. And Part D, of course, adds outpatient fee-for-service drug coverage. Medicaid, on the other hand, covers healthcare as above, but it also covers eligible nursing home services, and it potentially, under certain waivers, other long-term services and supports. So states can set the duration, though, the amount, the scope, et cetera, even on mandatory services. So even under mandatory coverage services, there still could be some state variation in what those look like. And so, for instance, if you're not paying attention to that potential variation, you may see a difference between states that is actually an artifact of some of those types of differences, as opposed to, say, the needs of the population or other things. Other services are state optional. I think I've got a list of those in a later slide. Examples would be pharmacy benefits, dental benefits, and so on. Another thing to note, as I mentioned before, is that waivers and managed care under Medicaid, those add possibilities and, again, variation as well. So the mandatory benefits, I'm not going to list all of these, but you can see that generally speaking, a lot of this, it's just fairly straightforward healthcare type services, as well as nursing facility and home health services. Okay. One thing to note importantly is transportation to medical care is also included here. State optional services, though, run the gamut. So we have prescription dental services, certain clinic services, physical and occupational therapy, case management. You can see the list. There's a wide list of things that are state optional, and we're not even talking about waivers yet. Restricted benefits are also possible. So qualified Medicare beneficiaries and selected income beneficiaries, so those are SLIMBs and QUIMBs, under certain low-income programs, receive Medicare premium and cost-sharing assistance. So not necessarily full Medicaid. Participants in family planning waivers, emergency Medicaid used to cover life-saving care, typically for people who might be, for instance, non-citizens. So you may find that there are some people who are, say, they would normally be age eligible. We've run into this in previous use of files where we had dual eligible enrollees. We had people who were over 65, for instance, and had had Medicaid covered services, but we're not in the Medicare program. And so one of the things that we ran into was the fact that we did have some people who were non-citizens in that sample. So it's just one example. Single and narrow benefit packages, such as things for like tuberculosis, breast and cervical cancer treatment, medically needy benefits, and starting in 2020, we have the COVID testing group as well. So there's not just, in other words, not just a full Medicaid program. There are also a lot of these kind of restricted benefit type programs that are much more specific. Notable features of Medicaid. So if you're used to thinking about, so one of the things that we come into is we've done our, we talk to people a lot about Medicare. And it's a little bit easier sometimes to talk about Medicare because we're very used to saying, here's what the Medicare program is, and that's just kind of it. With a number of features of Medicaid, you actually have so much variation that it's really important to talk through all of these features that could, again, lend some heterogeneity, could be a source of interesting analytic questions as well. So it's not to say that these are just weedy problems. They could actually be of interest to you as a researcher. So one of the things that we want to really note here are waivers. These allow certain parts, so the Social Security Act, certain parts of it allow the Health and Human Services Secretary to waive certain requirements. And so these are waiving requirements of the program. They are subject to rules. They are expected typically to be budget neutral, as well as other criteria. Those criteria can be sometimes relaxed, but specifically, but generally, I should say, there are some rules around when a waiver can happen. So it's not like this is just completely wide open. And you can find a list of state waivers at Medicaid.gov at this link. And there are a number of them. Two very common waiver categories that I'm just going to list now are Section 1115 for demonstration projects. These might waive exclusions on services or eligibility. For instance, certain behavioral health services, certain non-medical services like housing. So as people have over time, I think, become more interested in addressing problems around structural or social determinants of health, some of those things might be addressed through waivers. They may also waive eligibility rules to create restrictions. In other words, if certain people are supposed to be eligible, there may be a waiver of that eligibility rule. And so, for example, one thing that's happened recently were work requirements. Some states can choose to waive retroactive coverage, which we'll talk about in a second. So again, these are things where typically these things are required, but states can sometimes waive those eligibility requirements or uncovered services. The other one that I would mention, though, is Section 1915. These could, and then you'll see 1915 C, I, J, K. Couple of big categories here would be home and community-based services and personal attendant services. These might be used to cover assisted living, to select one's own care provider, maybe even housing for older and disabled adults, depending on the state. And so one thing that I know for people who study long-term services and supports, given that conventional Medicaid hasn't covered anything outside kind of nursing facilities, the use of these for HCBS or home and community-based services has been a big focus area for some researchers. So I mentioned retroactive eligibility, and again, this is something that we don't necessarily think about if you think about other insurance programs. So typically, what we would expect is somebody's enrolled in a program, they come in and they have, say, for instance, some type of ambulatory care visit in a clinic, and that gets covered. It may have a copay and so on. And then down the road, they might also have an acute service where they visit the emergency department. So that timeline is kind of what we expect. We expect somebody, they're enrolled, they get their services covered, the services happen, the services happen and are covered over time in kind of this straight approach to understanding, this kind of linear approach to understanding time, right? However, retroactive eligibility means that, for instance, if a person is not currently enrolled, they come in and have an emergency department visit and they happen to be eligible for services. One of the things that's important to note is that not everybody who's eligible for Medicaid is enrolled in Medicaid, which again is just something that's a little different than what we would typically see in Medicare, where generally eligible people are usually enrolled. So you have a number of different groups who are less likely to be enrolled even if they're eligible. If a person who's in one of those groups, they're not enrolled, they come in for an emergency department visit. One thing we've seen in working with health systems is that they will work with that person, or they will work with enrollment services to get that person enrolled, which can go back in conventional Medicaid, can go back 3 months to cover that service that happened. And again, this is partially because people who are eligible are not always enrolled when they come in for services. So one thing that we've run into in the past was we were wondering about the effects of, these eligible but non-enrolled individuals, whether that was censoring our ability to look at, say, emergency department visits or hospitalizations that might happen when they weren't enrolled. Like, would that just go under charity care or uncompensated care, and so it wouldn't show up in our Medicaid data? Well, depending on the state, and it's not always easy to tell, what could also happen is some of those people could end up being enrolled because of that visit. Now, of course, that creates other problems in understanding, understanding causal relationships and other things. If somebody is, for instance, is only enrolled because they had the visit, but it could be that you actually miss fewer of those visits than what you expect. But other visits that happen in clinics might not be picked up. So if health systems don't feel incentivized to look for coverage or get somebody signed up for coverage for a clinic visit, for a flu shot or anything else like that, some of those services could be missed. Again, there's not a lot of good kind of systematic evidence on this, but having spoken to a number of different health system representatives, billing departments, I know that these things happen. The degree to which is a little bit more of an open question, but it's just something to be aware of because it does characterize the Medicaid program in a fairly unique way.
Nate,
yeah.
2 questions that came up related to this.
Yeah.
The first one is emergency Medicaid mandatory? And I think I know the answer based on what you said, but I'm going to have you say it. Is it a mandatory benefit that all states have to give emergency Medicaid or this retroactive Medicaid?
I'm not sure. I have to get back to you. My guess would be no, but we'd have to verify that.
Okay, and then the other related question is there a link somewhere to states who employ retroactive eligibility?
So retroactive eligibility is a part of conventional Medicaid, and I believe if you look at that link for of waivers that I listed on a previous slide there, I think that if states are shortening, so there are places you can look to see where states have shrunk their retroactive eligibility period. It's I think like 7 states or something have gone back to like no, it only starts on the day of, I don't know if it's Idaho or someplace, it starts on the day of. Another, I think like Hawaii, for instance, might be only 1 month prior and not 3 months prior. I think that's listed in the waivers link, but we can also look for another source on that. It's pretty easy to find. I remember looking at it just a few days ago. But yeah, it's something like 7 states, and a lot of them, it's like they limit it to 1 month instead of 3 months. I think one state limits it to like the day of or so, the day before or something like that.
Thank you.
Managed care, another really important thing to note because, for instance, in Minnesota, I think managed care is very heavy component of the Medicaid program. So if you think about it, Medicaid fee-for-service, right? If you think about how that works, a service is provided, a claim form is submitted. A claim, when we talk about claims data, claims are bills. It's a bill for services with some added information to help determine whether that bill should be paid and so on, right? So that kind of claims processing and adjudication process is kind of, it's a very kind of linear process, right? There might be a full payment, a partial payment, or a non-payment. And so that creates a fairly direct link between the services that are provided, the payment that is decided, and the resulting administrative data that researchers would get their hands on, right? So there's a kind of a fairly direct linear process between what happens in the healthcare space, what services are provided, and what researchers actually see, right? So there's some pretty clear steps there. Now, Medicaid managed care, this is allowable under waivers for 1915B and Section 1115, have allowed states to implement managed care programs. So managed care in Medicaid can be through these waivers, right? So it can be part of the state, it could be statewide, it could be certain aid categories, it could be all aid categories. So there is still Medicaid managed care is not a single thing. It is a heterogeneous group of things, like all things Medicaid, I think. Managed care organizations provide encounter data of varying qualities. This is partially because of the nature in which services are essentially provided and then billed in a very different way. So instead of getting a partial, full, or denial of a payment for a particular service on a claim, right? Managed care organizations, of course, are paying on a per member per month basis, which is often based on, risk adjustment approaches and so on, right? And so when a service happens, it doesn't directly translate into a nice kind of clean set of claim file lines, right? These are encounter data that are kind of repackaged by the managed care organization and submitted to Medicaid agencies. And so what this means is that the state Medicaid agencies. So what this means is that there is data of varying quality, of varying kind of completeness of what all happens. And, if you're thinking about things like diagnostic codes, so for the diagnoses that people have that are associated with that claim form, because that's where we normally get them from in fee-for-service is in these claim form lines. We don't necessarily know how much of that is really translating into good quality data. Now, there are some resources that we'll talk about later on that help you to kind of try to comb through where the variations in that data quality might be. But just to note that managed care is, results in these encounter data that are, those records are just different in nature from fee-for-service claims. Just keeping an eye on time. So the nature of the payment can sever that kind of severs that direct link that we see in fee-for-service. There are a couple of different, the other thing just to note is that if you're saying managed care and Medicaid, there are actually a couple of different types of things. One is what I just said, the majority of this is risk-based managed care, where MCOs are paid a fixed per member per month fee. So this is a capitated system, and they assume some or all of the financial risk for care of their members. So this is a risk-based MCO. You'll see this under different terms like that. It may be comprehensive for all services, or it may be non-comprehensive. You may see it in behavioral health or dental or something like that. So that's the majority of it. However, there is another type of managed care that somebody could mean if they're saying managed care in Medicaid, and that is primary care case management, where a primary care provider receives a case management fee. So they're still reimbursed fee for service, but there's kind of an additional case management fee alongside that. So that's not part of the same program as the risk-based managed care organization delivered care. And you can find which states have which of these fairly easily. So managed care, as we said, can mean different things. So we were looking at managed care organizations providing that kind of risk-based capitated payment. Those MCO programs are in, you can see most of this dark blue here. Those are the states that have just the managed care organization risk adjusted capitated payment. There are some that have both those MCO programs as well as primary care case management. Those are in kind of the slightly less dark blue. Lighter still, where there is only primary care case management. That's again just 7 states. And then there's 4 states that have no comprehensive Medicaid managed care. Now, if you're looking at states that have these managed care organizations, risk-based capitated payment, most of those states that you're going to see are, you get pretty heavy managed care penetration in a lot of states. So you can note the dark blue here represents states that have over 75% of people in Medicaid on managed care organizations. Right? So Minnesota, for instance, where we are, very heavy penetration of managed care. There are a few states, if you get down toward the bottom, obviously the white states here are they don't have MCOs, but like 3 states would have less than 50%. So most states that have managed care organizations providing Medicaid managed care have half or above, and many of them have 3/4 or above of people in managed care. And so that's why we wanted to just note the importance of managed care, because it is a large part of Medicaid enrollment. And lastly, to get to the topic of the Affordable Care Act, Medicaid expansion and eligibility. So the Medicaid expansion under the Affordable Care Act, I'm sure people see 138% sometimes, and sometimes you see 133%. It's 133% in the law, but the modified adjusted gross income adjustment allows a 5% difference. So it's effectively 138%, but that's where those two numbers come. There are some subsidies for individuals between 133 and 400 of the percent of the federal poverty level through state health exchanges. The Medicaid expansion, importantly, expanded outward to adults without dependent children. And so this was a group that historically didn't necessarily, especially if you have individuals who were lower income or who were working in employment that didn't cover health insurance, historically fairly excluded or uncovered, unenrolled group, largely speaking. And so it's just a big shift. Income is modified adjusted gross income without asset or resource tests. States receive a full federal match for new eligibles for 3 years, then scaling down to 90%. So that's an adjustment away from strict, FMAP-based modifier. States are not required, of course, to expand Medicaid, and as we've seen, a number of states have not yet expanded Medicaid, or some have expanded, but have included some waivers, for instance, to either restrict eligibility or restrict services and so on. So Medicaid and health reform, so a benchmark benefit package, this increases Medicaid payment rates in fee-for-service and managed care for primary care services provided by primary care doctors to 100% Medicare payment rates for 2 years. As we know, Medicaid is paying at lower rates, so this raises that up. The Affordable Care Act created the Center for Medicare and Medicaid Innovation Testing to test payment and service delivery models aimed to improve quality and efficiency. So for instance, if states are putting in 1115 waivers to try new programs, CMMI can be involved in the testing and evaluation of those models. Also funding for pilot programs for medical homes, accountable care organizations. A good bit of my work in Medicaid has been around Medicaid ACOs. Demonstration projects and around integrated and coordinated care for dual eligibles. So just a lot of kind of new things going on that really, I think, add to the vitality, but again, also the heterogeneity of the Medicaid program. This is status of expansion as of July 2020. I don't know how much this has changed since, I'm trying to think. So by and large, we do have Medicaid has been, expansion has been adopted and it has been implemented. We have a couple where it's been adopted at that point, it had been adopted but not yet implemented. And then, a number of states where Medicaid expansion had not been adopted. So there are differences, of course, then in the types of eligible individuals that you're going to see in the data and so on. So again, this just adds to some of that variability. Medicaid eligibility before and after the Affordable Care Act. So the eligibility is based on categories, right? We're thinking about combinations of demographics and circumstances and needs. And of course, there are income limits. Pre-Affordable Care Act, you're mainly talking about poor children and their parents, pregnant women, certain categories of disabled individuals and certain elderly individuals. Post-Affordable Care Act, low-income limits are higher than what most states had previously, and now have added people who are low income, and again, as we said, low income childless adults are now added. So we have a lot of different variations on the eligibility here. You can see that most of the time now when we're looking at income levels, you're seeing 133%, quite a bit in places where there are income limits. You have a number of different categories here of people who are eligible based on their circumstances and their demographics or their living situation. So in closing, in the summary here, and I think we're just about at the end. Yep. Medicaid is a federally mandated, state administered, and federally and state paid program. So there's a lot of resulting state variability that we're going to keep mentioning over and over again, I think. Medicaid coverage is typically fairly comprehensive. So typically you have a comprehensive Medicaid package. There are some restricted programs. Waivers continue to greatly shape this program. Managed care is a large portion of Medicaid. Medicaid is a source of insurance coverage for children and adults, typically who are low income or who are disabled or have other needs. And lastly, Medicaid expansion and other changes under the Affordable Care Act greatly changed eligibility. So those are kind of our key takeaways. And of course, resources for other information are resdac.org. You could look at macpac.gov, medicaid.gov, and another source that's useful is Kaiser Family Foundation.
So Nate, we've got a couple of questions so far, a couple more. So one person wanted to know, and I just lost the chat, the starting date when managed care organizations started providing data. And they mentioned that they've got data going back to 2012, and they were wondering the coverage of managed care, and they used the phrase encounter, which which sounds a lot like Medicare. And so I think the question might be just as much, is that also a Medicaid thing?
Yeah, so we do have, so you get encounter records. They're still part of the same data. Unlike so our Medicare data, for instance, fee-for-service data and encounter data are separate in the files that researchers get. So you get an encounter record still with these Medicaid data. As far as when they started submitting, I am not sure. That is something I don't. I know that we've used data back to 2011, I think, but I don't know the actual date. So that's something we would have to check on.
Okay, and then somebody else wanted to know where they would find information on managed care organization penetration rates across states and over time.
I would say that one of the easiest to use resources, I haven't, and it's probably just because it's the one that I use more, so I'm sure there are other good sources. I would say that Kaiser Family Foundation tends to be very useful for looking up things like that, in terms of either showing maps or tables or those kinds of things. I believe you can get over time as well, pretty sure. So I would go to Kaiser Family Foundation as probably an easy to use resource. But again, that's the one I use. I wouldn't, if somebody has a better one that they want to promote, feel free to share it in the chat, but that's where I tend to go for that kind of information.
Okay, and then let's do one last question so we don't get too far behind schedule. But when analyzing Medicaid data from CMS, will researchers be able to see payments covered by managed care plans as well?
Well, again, it's important to remember that payments under managed care are per member per month. So you're actually looking at a per member per month amount rather than a payment for a service. We have, I think, looked at, trying to remember what we've done. So sometimes what people will do is they will take cost ratios from fee-for-service and use them to like impute some kind of cost for managed care. That's one approach. I'm not gonna necessarily endorse one approach to handling you know, cost information, because I think there are always going to be some complications to exactly how we try to get at, you know, costs and payments under managed care. It is not a simple thing. Like I said, I've seen imputation type approaches. That's one thing, but again, you have to have fairly good confidence that the ratio would hold up or be comparable between fee-for-service and managed care, which isn't necessarily the case. So there are approaches to trying to do that, but it does require some assumptions to be made. And I would make sure that you get as much contextual information as you can if you're going to use a particular approach.
Okay, thank you.